So I suppose I'd just do the same format as before. I'm sure there's questions online, but I'd love to ask you guys here if you have any questions. We have been going for a little while, so I suspect they might have dried up. But Kerry, yes.
How do you give them, like in those trials, how do they give the mice PSC?
Okay, that's a good question. How do they give mice PSC in the trials?
There's no perfect mouse model of PSC, but when they do mouse models of a disease, they either give the mouse a chemical that then causes inflammation and scarring the liver, which actually is called DDC in this case, or they manipulate the bile duct so they can, for the little mouse, they can close off the bile duct and it causes inflammation and scarring. So, and they can also do genetic manipulation of the mouse. So there's quite a lot of mouse models, and some of the ones I've showed have been two of the main mouse models. It's not very nice for the mice. There's a huge amount of ethics behind it, and they manage to do it ethically according to animal ethics.
I would like to ask a diet question of Alice. So Alice, do you, I suppose it's a broad question, what proportion of patients with IBD PSC manipulate their diet? What are the most common diets you see? And I suppose you've sort of talked about it a bit, but what are some of the issues with those diets?
All very good questions. So in clinic, so we have an IBD clinic here, and we certainly see that almost everyone that comes through clinic has tried something with their diet, and it can be very broad and varied. People will have tried, gluten-free diets. They will have tried, keto diet. They will have tried vegan. They would have tried, different anti-inflammatory protocols, as we've heard today. And I think what is really difficult is that some people have symptoms, some people have inflammation with inflammatory bowel disease, and a lot of these diets, they just have not been tested in scientific studies. And the problem with that is they risk nutritional problems. Probably the biggest nutritional problem that we are now starting to see, and this probably correlates with increased social media and internet, is food anxiety and disordered eating and disordered eating patterns. This is very different from an eating disorder. This is food confusion, where people have tried so many different things to try and help themselves in the absence of a treatment, that they are then really unsure what to eat or what's okay to eat occasionally. And so definitely most of my consults are spent unpicking some of the information and helping people to make sure primarily their diets are nutritionally balanced, and making sure that there is correcting dietary misinformation so that people are able to enjoy food. Because at this point in time, we, beyond the dietary guidelines for PSC, we just don't really know what the best way to eat is.
So do you recommend a gluten-free diet at this stage?
We do not recommend a gluten-free diet. So although there has been some data coming out of Europe, there is a research group that is looking at the gluten-free diet. The data has some, what we would say inconsistencies or holes in it. And certainly our research group is particularly interested in looking at manipulation of the gut microbiome. In people that do not have celiac disease, a gluten-free diet can be problematic because it is low fiber. So it lacks the fiber to fertilize the gut microbes. And it can also be highly processed because of the way food manufacturers do it. That does not mean if you have celiac disease and PSC, there is a problem, but it's about education around a good quality gluten-free diet in that situation. But for everybody else without celiac disease, it's not something we recommend.
Yes. Paul, do you talk about diet?
Oh, well, I was going to ask a question of you. What do you say when patients ask you, well, what should I do? I read all this stuff and there's this and that. I'm so confused. What should I do? What do you tell them? And I'll answer that question.
Certainly. So there's probably two parts to it. I think probably the first part is trying to understand from the patient perspective what they want to do. I think that is really important because, and do people want to try and manage particular symptoms, and are there different strategies, and it depends where the symptom is. So if it's gut symptoms, there are lots of different dietary strategies. If it's itch, there is less well-known dietary strategies that can help with that. The dietary advice, it needs to be personalised. It's actually a really difficult question, but the overarching aim in the consult is to try and match patient expectations and perceptions and understanding of diet, and trying to get them to a point where they're eating to enjoy food, their diet is nutritionally balanced, but certainly a big focus of our consults is trying to get people to eat more plants and fibre.
Thank you. Yeah, look, in paediatric practice, almost everyone tries some form of diet as well. I'm a big fan of enteral nutrition to induce remission in Crohn's disease. I think there's really good evidence for that. Beyond that, I think the evidence probably isn't so much there, but yeah, I think when I get asked the question, what should I do? I guess if they really want something, I sort of say something as vague as perhaps be a little bit guided by the Mediterranean diet as a general type thing without being too specific. That would be my sort of go-to. If they've got symptoms that might be IBS, I would say speak to a dietitian and consider whether there's a role for a FODMAP diet. But there's a whole lot of diets out there, and I do think, particularly if they're obsessively followed, there's the potential for more harm than good. But that's just my perspective.
I don't think you mentioned this study, Alice, but there was one large retrospective study where they looked at people with PSC and what they ate compared with people who didn't have PSC as controls. And they then, the foods that were in abundance, they wondered whether associated with developing PSC. And a lot of the barbecued meats and fatty meats and processed meats came out as being harmful and associated with developing PSC. It was a while ago that I read the study. It's about 2000, yeah, it was about 2016 or so. So I don't have the benefit of an IBD dietitian always in our service. We do have one who is there some of the time, but it's not as advanced at the Queen Elizabeth. But I just say to people, the more you can prepare your food yourself from whole foods and incorporating lots of plants and fibre, just that is the best way. You can do it yourself rather than open a package as well. For simple measures.
Just moving away from diet for a minute, although there are some more diet questions on here. We have got a question about if you're enrolling for the FMT trial and whether they need to be in South Australia. And we'll probably add to that, what are a couple of basic things, you know, are there just a couple of basic parameters to help people decide if they should be inquiring about that?
Yeah, so at the moment we have ethics approval for the Queen Elizabeth, and we will be expanding that to include the Women's and Children's Hospital. So South Australia wide at the moment, but depending on how we're going, there will be some difficulties, I think, in involving interstate participants, but we may look at needing to do that. In terms of the entry criteria, so we at the moment have a age range of 16 to 75, but we'll probably look at reducing the age to 12 and above. The only other thing is that we are excluding participants with autoimmune hepatitis overlap or other liver disease.
And I know I've looked at a lot of my patients, but they might be eligible. Would they know I've looked at that or not? But having a normal ALP also excludes you as well. So the ALP just needs to be raised above the normal limit.
If they're willing to travel, to South Australia, if that's what the question is that something that they should contact you about if they were willing to travel for the visits, or at this stage is that something?
Yeah, so certainly if they're willing to travel, yes. And you know, we can try. There's 11 in-person commitments at the moment, which might be doable for the patients in South Australia, but I think we can, because you'll have to pick up the stool capsules and they have to be frozen, and you have to drop off a stool which also has to be frozen. So we would need to probably, you'd either need to come for 11 visits or we'd need to incorporate other sites around Australia. But definitely reach out. We'll have a sign-up sheet here for anyone that's here. Just leave their email address and number if they want to be contacted when the trial starts. Or my email was at the top there if they wanted to contact me.
We can put it in.
We can pop it in the chat, and if you get lost in that and you can't find DJ, you can always email us at PSC Australia and we can pass that on.
And I just want to ask either DJ or Rob, do they taste like poo?
Rob might better.
Well, yeah, no.
No.
So the process of lyophilization is quite involved. So it's just like snap freeze drying something. So what it does, it preserves the viability of the organisms in it. So it's not like eating poo. And so the lyophilization process snap freezes and preserves their viability. But then there is an encapsulation process as well, which means that they travel further down beyond the gut. So they won't be releasing all those organisms in your stomach. So you shouldn't have smelly burps or anything else like that. It should pass further down before the organisms release. That's really important as well, because you don't want the bugs to all discharge into the really acidic environment of the stomach, which would knock them off. So you get them going further down and then they can survive and transit down. And the point is you're trying to recolonize your gut with these healthy organisms. So you're repopulating with those bugs. But it does sound, conceivably challenging, but the process is avoids that. Yeah.
Anyone else? First.
Kate, you can go.
There's about 22 to 23 genes that have been associated with PSC, as well as something called HLA subtype. They're almost all immune related, but there are some that are microbiome type related and gut microbiome related. However, whilst there is an increased risk in certain three relatives, it's only small, like in the single figure percentages. So we do see relatives with PSC, but if you have PSC, the chance of passing on to your offspring is very small. And it's what we call a complex condition where there's a component of genes, but also the environment. And so it might be that you're...
I think that's muted. The answer was yes, there is a genetic component, but there is also a huge amount of environmental component. And I suspect a lot is from diet. And there is something to do with the environment. The higher you go in the Northern Hemisphere, the more PSC there is. The highest prevalence, I believe, is in Norway. And they've got a huge Norwegian PSC centre there. Some of the best research, some of the first genetic PSC research comes out of there. But there's this genetic component which probably primes you that you're at risk of it, and then something happens that triggers it.
But I think it is reassuring from a patient perspective that you're not just guaranteed to pass it on. It's not a reason for voluntary childlessness, for example. It is a very small genetic component, and it's called multifactorial. And we're really focusing on the environmental factors, which is more that gut microbiota, what's happening in the environment that's affecting the immune system and the gut. We've got a question.
So in saying that there are genetic factors, does that mean that somebody can have those genetic factors, say some or whatever, and never
100%.
never have it and never show signs of it, and then say have it come further along the line in the family, say if it's got that genetic side? But I suppose more the question there exactly is, can they have everything, say, for it and then never get it in the first place?
100%. Yep. There's a whole list of genes, and these are tiny little changes in the genetic code. The ones for PSC overlap with the ones from inflammatory bowel disease. There's hundreds of them that have been suggested overall. Each of them has a tiny bearing on whether or not you get the disease or not during your lifetime. So there are some people with the full house that will never get it. There are some people with just a few that will. So what is the factor then during a lifetime that is really driving that disease? And I think that's where the research is going. There's been 20 years spent on genes, and that's still happening, and it's really important. but there is something in the environment compounding it, because we're seeing a lot of illnesses increasing and changing in their rates and prevalence. IBD being a really, really common one. It's tripled since the 1990s. So there's a big change going on. And our view probably that there's a big dietary contribution to that, as well as other environmental factors like hygiene, antibiotics, and just the way that we're living.
I just want to mention one of the biggest genes is an HLA gene which stands for human leukocyte antigen. And you inherit your HLA genes. Everyone's got different, like certain subtypes of HLA genes from your mum and your dad. And if you have this specific kind of subtype of HLA gene, then you are much more predisposed. And almost everyone with PSC has these subtypes of HLA. But what is HLA? It's actually your body's immune system's way of what things it recognizes and how its immune system responds to certain things, which are microbes, dietary, proteins, etc. So actually, the genes are actually something that prime your immune system to be overreactive or react in a different way to things it's exposed to, which makes sense that it's an environmental trigger, because it's actually that your genetic predisposition is making you have an abnormal reaction to outside things. And that's probably going to be things introduced through the gut to the liver.
Terry, do we have any other questions? Otherwise,
I do have, there's a couple more, but there's one that I would, I think, might be relevant to quite a few people, for Dr. Alice probably. Having PSC, a lot of people really, but this person's commented that they find it very hard to actually gain weight in PSC, so potentially a bit more advanced, or maybe not. But yeah, they're just asking what you would recommend to help in that, when you're struggling to gain weight with PSC.
Yeah, definitely. That's a good question. Look, it probably takes a personalised approach, because within, the information that I presented on like an anti-inflammatory style diet, which is in line with the principles of the Mediterranean diet Paul was talking about, and the Australian Guide to Healthy Eating, there are lots of foods that are naturally high in fats, plant-based foods, so things like avocados, nuts. There are lots of different grains that are very high in protein that you can include in your diet. The default would be to eat a lot of sweet, fatty, processed foods. That has implications for the liver. There is oral nutrition support drinks that we use in pediatrics and in children. So like high energy protein drinks that can be used. It really needs to be personalised to the individual, because, for example, recommending that someone go and start eating lots more peanut butter on toast, for example, between meals to gain weight in a healthy way that's in line with the Mediterranean diet. If they have irritable bowel or they have inflammatory bowel disease, that might not be the appropriate strategy for them. So it actually is really difficult to give generalised dietary advice in this context, particularly when PSC commonly coexists with other diseases that can affect the gut. So sorry, that's not the greatest example of what to do.
That's good, thank you. Can I say one more thing?
If you have advanced liver disease, we do recommend you have a late night snack. And so often a high energy, high protein diet is recommended in more advanced liver disease. And one of the key components is having something just before you go to bed that's in line with whatever you're eating, but often high protein.
Mm-hmm. Thank you, that's good. We do have a couple of other questions on here, but they might be able to be answered like we did in the break before. I might get a couple of you to come and answer online, just since we're tracking over time a little bit.
Well, thanks, everyone. I'd like to close this session out. We didn't acknowledge that it's actually Rare Diseases Day. I'm not a Chelsea fan, but this is stripes. You'll see many people have stripes, but 29th of February, it happens once every 4 years. And this is Rare Disease Day, so it's a real coincidence and something we didn't actually think about when we planned this. But I'd like to thank our panel and speakers, and Kerry, our patient advocate, for being here and putting together what I thought was a really fantastic forum. And thank you all for being here, and thank you all to those online. So really a great night. Thank you very much.
And can I just say a really huge thank you to your crew over here in Adelaide, who every time we came up with a problem that I couldn't solve from Melbourne, you managed to solve. So
Yeah, you've been amazing over here. It's been a really wonderful thing that you've been able to put this on for us as well. So thank you very
Thanks,
much.
Gary. It's been great working with you. Thanks, everyone. Thanks, everyone online.